Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's March 2021 issue. There are 3 articles, 2 of which focuses on COVID-19, that have been selected as our Editor's Choice or Highlights articles this month. Our Editor's Choice this month is an original article entitled Outcomes of COVID-19 with the Mayo Clinic Model of Care and Research. It is authored by Dr. John O'Horo and colleagues from Mayo Clinic in Rochester, Minnesota, Jacksonville, Florida, Scottsdale, Arizona, and other Mayo Clinic health system sites. Substantial heterogeneity exists in the type, severity, and developmental tempo of complications of COVID-19. Heterogeneity also exists in the reported outcomes, including mortality in patients cared for with this condition. In the present issue of Mayo Clinic Proceedings, O'Horo et al. Present their retrospective analysis of 7,891 patients with COVID-19 diagnosed and managed at Mayo Clinic sites from March 2020 through July 2020. In this population, 11.3% required hospitalization, with 4.5% necessitating management in the intensive care unit, ICU. The overall mortality was 1.1%, with mortality rates rising to 7.1% and 11.9% in patients who were hospitalized and those who managed in the ICU respectively. A key finding in this study is that these mortality rates for patients managed in the inpatient, ICU, and outpatient settings are substantially lower than those previously reported in other analyses of outcomes at other centers. Additionally, the mortality rates observed by O'Horo et al. For hospitalized patients were lower than that observed in specific patient populations, such as, for example, patients treated with convalescent plasma or remdesivir. O'Horo et al. Offer several possible explanations for such improved outcomes. A salient consideration is that as the pandemic loomed, the leadership at Mayo Clinic convened assorted teams tasked with formulating relevant processes and protocols in responding to the pandemic. Such teams brought together complementary expertise relevant to their assigned directives and responsibilities. Initiatives were coordinated overall by the SARS-CoV-2 COVID Enterprise Task Force, and relevant work streams involved inpatient clinical trials, treatment review groups, outpatient clinical trials, critical care innovations, data science and registries, and remote monitoring. Operationalization of relevant work streams and initiatives were effected by the COVID-19 Data Governance Task Force, the treatment review panels, which evaluated hospitalized patients for specific clinical trials and therapies, and the COVID-19 Frontline Care Team, which was involved in outpatient care and monitoring patients by telemedicine. Such specifically targeted yet integrated approaches enabled the provision of team-based expertise and specialties in patient care that was consensus-based. It also enabled an enhanced availability of therapeutic options because of clinical trials and other possible therapies. And indeed, COVID-19 targeted therapy was administered to 77.5% of hospitalized patients. It fostered the careful evaluation and monitoring of patients in the outpatient setting. And finally, it forestalled surge situations by ensuring requisite functional readiness and capacity. O'Horo et al. Also discuss other considerations relevant to their findings. First, mortality rates for COVID-19 have generally tended to decrease with time, and this may reflect the fact that initially in the pandemic, symptomatic patients were more likely to be tested and diagnosed, whereas later in the pandemic, testing more likely involved individuals without symptoms, and thus those with more benign disease. Second, The initial spreading of the pandemic to the United States did not involve Mayo Clinic sites, thereby providing added time for preparation as well as insights acquired from the initial experience of the disease and ways it could be managed. Third, through telemedicine and other strategies, the COVID-19 frontline care team diligently monitored COVID-19 patients in the outpatient setting, and thus was positioned to judiciously and expeditiously escalate the care of these patients should their condition require it. This timely analysis by O'Horo and colleagues imparts several valuable insights. The central one being that the coalescing of expertise, disciplines, and resources in a team-structured framework and in a consensus-founded approach can significantly improve the care and outcomes in patients with COVID-19. Our first highlight this month is a special article entitled Multi-Level Evidence-Based Strategies to Address COVID-19 Vaccination Hesitancy in Clinical Settings. It is authored by Dr. Lila Finney-Rutten and colleagues from Mayo Clinic in Rochester, Minnesota. It is generally recognized that strategies that will successfully restrain the COVID-19 pandemic involve effective vaccination programs, relevant public health policies, and personal behaviors such as masking and social distancing. For vaccination to be a successful strategy, the vast majority of members of a community should accept its value and necessity and accordingly be vaccinated. A challenge in the current pandemic is vaccine hesitancy, the latter representing a disinclination to be vaccinated because of either individual mistrust, uncertainty, or indifference regarding vaccination programs. The basis for vaccine hesitancy is then discussed, including first, how vaccine attributes are perceived, for example, their efficacy, duration of protection, adverse effects. Second, political factors, for example, accelerated federally funded vaccine development and emergency use authorization may exacerbate concerns about vaccine attributes. And third, personal attitudes, for example, individuals with insufficient understanding of the gravity of the current pandemic or with a predilection for natural immunity rather than vaccination-conferred immunity. Finney-Rutten et al. Summarize evidence-based strategies. Interventions at a policy and community level include, for example, making vaccination programs accessible in childcare centers, schools, colleges, and women, infant, and children programs. At an interpersonal level, the interaction between healthcare professionals and patients is a central one, as patients generally value and heed the recommendations of healthcare professionals. Emphasis in presumptive announcement time communication by healthcare professionals is generally preferred. Individual level interventions refer specifically to healthcare providers and patients. As regards the former, examples of more effective communication are provided, and the need for requisite education as regards COVID-19 vaccination is underscored. Links to websites with such educational resources are provided in the article. Patients should be appropriately educated by COVID-19 vaccination, and information shared by healthcare providers to patients should generally be framed in a positive rather than a negative manner. Interventions at an organizational level are listed by the authors, and these include standing orders, audit and feedback, reminders and recalls, and point-of-care prompts. Finney-Rutten et al. Are to be commended for highlighting the central challenge of vaccine hesitancy faced by national and international endeavors to restrain the COVID-19 pandemic, and for synthesizing evidence-based strategies that may be pursued at varied levels to remediate this challenge. Our second highlight this month is a review article entitled Clinical Management of Hyperkalemia. It is authored by Dr. Biff Palmer at the University of Texas Southwestern Medical Center in Dallas, Texas, and colleagues from numerous national medical centers and universities. A comprehensive review on hyperkalemia is merited, especially in light of two key developments in recent years. The first is that agents which inhibit the renin-angiotensin-aldosterone system are now established as therapeutically beneficial in such conditions as systemic hypertension, diabetic and non-diabetic chronic kidney disease, heart failure, coronary artery disease, left ventricular dysfunction, and diabetes. And yet these agents pose a real risk of hyperkalemia, the latter complication not infrequently curtailing their use in such conditions. The second is that new potassium binding agents are now available in clinical practice that do not impose the risk of intestinal ischemia and colonic perforation, as does the older potassium binding agent, sodium polystyrene sulfonate. These new agents, patiromer and sodium zirconium cyclosilicate, may be more effective in treating hypokalemia. Palmer et al. Provides such a review in the current issue of Mayo Clinic Proceedings, and one which draws upon their search of the relevant PubMed literature between 2000 and 2019. Potassium homeostasis is maintained by an interplay of internal and external balance. External balance enables potassium excretion, 90 to 95% by the kidneys and the remainder by the gut, to match oral potassium intake. Internal balance acutely safeguards plasma potassium in a normal range, either by promoting intracellular uptake of potassium via the cell membrane sodium-potassium ATPase, which is stimulated by insulin and beta-2 adrenergic agonists when plasma potassium rises, or by allowing cellular egress of potassium into plasma as plasma potassium falls below normal levels. Renal potassium excretion is dependent upon glomerular filtration rate, GFR, distal nephron delivery of sodium, water, and impermeant anions, and by aldosterone, which promotes potassium excretion and sodium reabsorption. Palmer et al. Discuss the risk factors for hyperkalemia, including disease such as chronic kidney disease, heart failure, and diabetes, and drugs such as agents that inhibit the renin-angiotensin-aldosterone system, non-steroidal agents, calcineurin inhibitors, beta blockers, heparin, among others. They also discuss how the predicted probability of mortality rises with increasing levels of plasma potassium, and that this is further augmented by the presence of diabetes, heart failure, and chronic kidney disease, especially so when these conditions are concomitantly present. The risk for hyperkalemia generally increases as GFR is reduced. However, reduction in GFR per se does not cause hypokalemia only until the GFR approaches 15 mL per minute because of adaptive increments in potassium excretion in surviving nephrons. As a corollary, hypokalemia occurring when GFR is only mildly or moderately reduced usually reflects the presence of some additional underlying factor. These include the following. First, agents that inhibit the renin-angiotensin-aldosterone system, or some other drug that impairs potassium homeostasis. Second, hyporeninemic hyperaldosteronism, a complication of diabetes. Third, tubular resistance to aldosterone. Fourth, extracellular release of potassium. Or fifth, excessive oral potassium intake. Palmer et al. Discussed the cardiac and other risks of hypokalemia and how cardiac risks may be modified, for example, either heightened by pre-existing cardiac conduction abnormalities or relative hypocalcemia, or may be more readily tolerated because of adaptation to chronic kidney disease. Palmer et al. Reviewed the management of acute hypokalemia, providing the rationale, onset of action, and efficacy for each modality. In addressing the management of chronic hyperkalemia, Palmer et al. Summarized the recommendations by various societies regarding therapy with agents that inhibit the renin-angiotensin-aldosterone system, and as such therapies relate to normokalemia and hyperkalemia. The authors also summarize key findings from clinical studies assessing the efficacy of sodium polystyrene sulfonate, Potassium, and sodium zirconium cyclosilicate. And with regard to each of these agents, they discuss their mechanism and onset of actions, dosing, effects on other ions, and their adverse effects. The authors underscore the potential role of Potassium and sodium zirconium cyclosilicate in mitigating the risk and occurrence of hypokalemia incurred by agents that inhibit the renin-angiotensin-aldosterone system. Developed because of concerns regarding sodium polystyrene sulfonate and representing a preferred therapy for chronic hyperkalemia in general, these newer potassium-binding agents may enable, in particular, the continued use and the beneficial effects of agents that inhibit the renin-angiotensin-aldosterone system in an increasing number of conditions. You can access these highlights and editor's choice articles free of charge during the entire month of March when you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org. You will find links to our social media by clicking the buttons at the bottom of any page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings issue summary and Author Insights podcast recordings, which are available from our website on the homepage as well as through iTunes. You will also find our online-only feature, Pioneers and Legends in Medicine, which are video interviews of people who have made a strong impact in their field of study. You will see many news stories on our website that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content and articles published online ahead of print. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.